The following presentation is a production of Ride the Wave Media.
It's the Best Birth Podcast, where we interview experts that elevate you as you prepare your heart and mind to have the best birth.
Each episode will interview professionals so you are prepared for pregnancy, birth, and postpartum. Our experts will build your confidence and empower you to trust your intuition throughout your pregnancy.
This audio is taken from videos on YouTube. Watch the entire episodes on YouTube at Birth Made Mindful. Welcome to the Best Birth Podcast. Today we are interviewing Dr. Jon Schmidt, a pediatrician who is here to help us feel confident in raising our young children.
Dr. Schmidt loves partnering with parents in caring for their kids as a pediatric doctor of 9 years. He is passionate about efficiency, and he has 5 kids who enjoy riding horses in Oakley, skiing at Alta, and hiking in Glacier. In his spare time, he can be found in his woodshop or welding a new project.
Welcome to the podcast.
So good to have you. Yes. We just want to dive into a few things to ease parents' minds. I feel like that was one thing I had as a new mom. I just was wondering, is this normal? Is this okay? Where should we turn in situations like that?
Yeah, I think there are a lot of unknowns in having kids, right? You grew up, you watch your parents be parents and their way of parenting. Your friends start having kids, and it feels like a very normal step until it's you, and then you don't know what to expect. And so the nice thing about it is it happens whether you're ready or not. You have 9 months that seems like a long time until it's not. But I think I think it's worth answering some of those questions and exploring some of that, but also relax and enjoy it. It's been going on for thousands of years, and it turned out pretty good for your ancestors. So
I think that's such a great perspective to remember that there's nurture and nature, but that we also have supportive providers that can help take care of us. Like when our kids get sick, or if we happen to have a child that is neurodivergent or has other disabilities, that you guys are the professionals that are going to help us bear those burdens. I wanted to talk a little bit about the beginnings.
Mhm.
So when we have our baby, is the pediatrician the one who kind of takes over care right away in the birth room?
it's a good question. My patients are the babies, and you're not the baby until you're not with your mom anymore. So you got to come out. Typically that would happen in a hospital setting where we would come in and round in the mornings. Before clinic, we'd show up at the hospital, and babies born overnight would get examined. You're supposed to be seen at least once a day while in the hospital, so we'll show up then. With C-sections, it's a little interesting because typically if it's a high-risk C-section, we'll be called to attend in the delivery room or in the OR. And in that setting, the OB's in charge until baby comes out. Now, the difference is the OB is going to be in a sterile gown. So I don't run over there and grab the baby. We get handed the baby. And if that's an emergent situation, that happens very quickly. If it's not, we're just observing the birthday party.
Mhm. And what a fun birthday party. I remember you were at the birthday party of my first son, and I had not yet selected my pediatrician.
Yeah.
My son came about a week early. My water broke, and then I had a long labor and ended in a C-section. But I remember just feeling so much relief that there were a lot of people there that could help with our son, and he had a little bit of a NICU stay. But tell us a little bit, these first moments of birth, when the baby's born, I guess the first thing, like you mentioned, you have the placenta and you've got this cord clamping deal.
Yes.
So what do you recommend for parents? Do we need to be stressed about the delayed cord clamping, or will the hospital allow the time is needed for all of that blood to, get into our baby's bodies?
Yes. It certainly has become, to my understanding, the standard of care is to do some delayed cord clamping. One of the biggest problems that we see in newborns universally is bilirubin. We're checking everybody's bilirubin, that jaundice yellow color, and delaying too long can increase your risk of jaundice. And so I think after the study showed that it was probably a good idea and helped in a lot of ways, there was still some hesitancy because it's not without risk. That 30 to 60 second window is kind of what's become the standard, because too much certainly can, because bilirubin, the jaundice is a broken down red blood cell. So the more you have, red blood cells right at birth, then the more broken down red blood cells you'll have. And so your jaundice could go up. Now, not having enough is also a problem. So there's a sweet spot, and it seems like that 30 to 60 second makes sense. Typically, that's an OB call. So talking to your OB about how they like to do it. And then there's the scenarios in kids who, if they have a bad tracing, meaning that this baby's not getting oxygen from that placenta, this is the crash C-section scenario, it doesn't make a lot of sense if you know that placenta is not giving what you need to stay with it any longer. And so it doesn't always go perfectly as planned, but in general, that's what we try to do.
And what about cord blood banking? It's something that seems like a hot topic, but most of us don't know much about it.
Yeah. I don't know that I have a ton of experience with it. I mean, that idea that we'll need this someday, it's probably some more of a luxury than a necessity. If you feel like that could serve a purpose for you and you can afford it, I don't know that there's a downside to it. Medical technology changes so much, it's hard to know how valuable that's going to be down the road and how different that's going to be from blood draws or other things that are out there.
Yeah. You spoke to jaundice a little bit. I want to ask the question, when your baby comes home and all of a sudden on day 2, they're looking a little bit yellow, what can a parent do to improve their situation?
It's tricky. So jaundice is a normal physiologic state. There's some thought that it may actually be protected from infection. But until your liver really starts metabolizing that broken down red blood cell protein, you're going to have a little bump. So every baby gets a little yellow. And our concern is that if it gets really high, it crosses the blood-brain barrier and then it can cause permanent brain damage. That's an extremely rare scenario, but it's extremely preventable. And so there's really not a lot of room for error there, which is why we check everybody and we're watching it closely. Things that help bring your bilirubin down. One is feeding well. If you're eating well, you're usually stooling well, and it comes out in the stool, and that's that yellow seedy stuff. So if you're not eating well, you're losing a lot of weight, we worry those kids are going to have a higher bilirubin. And that's tricky because you're not supposed to eat well the first few days. And so, the question's always, well, do I supplement? So if supplementing helps your baby eat better, or at least get more volume, and you stool better, that can help your jaundice. But we don't recommend everyone supplement. Breast milk is great and recommended, and usually you just have to give it time. So I think it's important to work with your provider to see, okay, where was that first baseline bilirubin? If it's in a low area, you have time. If it's creeping up on us, though, it probably makes sense to either pump and supplement or do something to help get things moving through the gut, because that's going to help. By day 4 to 6, usually the bilirubin is being metabolized pretty well by the liver. The places you get in trouble are some genetic conditions or antibodies that will break that down pretty quickly. And those are usually the kids we see that have the big problems. But that's what you're looking for. If your first bilirubin is high risk, then we're going to watch those closer and repeat them more. If it's low, we probably have time to let nature run its course. The way you treat it, if it is high, is the wavelength of light that is blue, that spectrum of light, tends to break it down in the skin really well. So if you're really high, we often recommend using Billy lights. And there's blankets and lights in different ways, but that light will break it down in the skin. And it's all about exposure to skin. So you're stripping your baby down to the diaper, covering their eyes with glasses, and getting a lot of exposure to skin.
Is that when they look like they're in the tanning beds?
Yeah. Now, the other way to do that is just put them in the window, let a little sunlight come in. Of course, sunlight has ultraviolet and other wavelengths. So if you're really high, that's probably not going to be enough, or at least not that you want. It's also hard to quantify that, right? Is it north sun? Is it east sun? What kind of sun is this? So in a kid who's looking a little yellow but not in a danger zone, I think that's probably very reasonable. But if it gets really high, you want to have just the blue length of light, and you want to have that exposure throughout the body as much as you can.
That's so wonderful to know that there's kind of natural ways and medical ways that we can help that. I had a couple of questions about the other procedures that are offered for the infant right after birth.
Mhm.
So one of them I can think of is the vitamin K shot.
Yes.
Can you tell us a little bit about what it is and how it helps our babies?
So vitamin K, I think the big confusion is this a vaccine or is it a vitamin? It
Mm.
is a vitamin, so there's not mercury in it or that way, um, and it's a natural vitamin in our bodies. Since 1961, it's been recommended every baby have it. This isn't new. It's not experimental. Um, there's concerns about does it cause leukemias and other things. We've had multiple very large studies showing it's not. That's not causing those things, and so it's safe, and it's been shown to be safe for a very long time. The important thing is your babies aren't born with a lot of vitamin K.
Hmm.
Universally, babies are low on vitamin K. And unfortunately, they don't absorb it well through the breast milk. So even if mom's supplementing or has a good supply, they don't seem to be getting it. So you have this scenario over the first 6 months of life of having bleeds. The serious bleeds are brain bleeds, but you can get them in the gut as well. And babies who have these bleeds, well, first of all, if you don't get the vitamin K, your risk is about 80 times higher of having a bleed. Of the kids who get bleeds, about 20% or 1 in 5 will die of that complication. So if you look back in history or your family history, you may notice not every baby made it. That was because of a lot of reasons, but this was one of them. It's really hard to predict which kids are going to have those bleeds. All babies have birth trauma. It can be a variable in how much the trauma is there, but all babies get squeezed. And so that makes us worry. But then over the first 6 months, they're not always in a little cocoon. And so that risk goes on. And as pediatricians, one thing we worry about is sometimes those symptoms start really subtle. So we worry we could miss that, right? My baby's really irritable. Okay. Is that colic? What is that? But certainly it can progress to something a lot more serious. So that is one. I guess the other question we should answer is oral versus the intramuscular shot. Certainly the one-time intramuscular shot is the most effective. There's small studies, not a lot of good information about oral. In fact, right now, the only way I can order it is I have to put a special note in the pharmacy and say, hey, take the intramuscular and give that in an oral dose, drink it. There's no FDA-approved oral vitamin K. That's the problem. So, and then it's hard, it's multiple doses and missing doses, and how effective is that? It makes that recommendation pretty tricky versus one vitamin K injection at birth, taking care of that. Watching your baby get a shot is not anyone's idea of a good time, especially a newborn. Skin to skin and breastfeeding is a really good way to soothe them after that. But you have to balance the risks. And in this scenario, I would say this is not a risk that's worth it because the cost benefit, it's just not there for me.
How is eye ointment used after birth?
Yeah. So that's another one of these first things we do right off the gun, right? Eye ointment is erythromycin usually. It's a very common antibiotic. It has a very low risk of causing irritation or allergy type stuff, but that certainly is a risk. Personally, I've not seen it as a problem. The problem there's really two things. I mean, it's an antibiotic, so it's killing bacteria. Certainly for diseases like chlamydia, gonorrhea, that can cause permanent blindness, it's a really helpful thing. So your doctor doesn't know your whole history. So on a population approach, you would say, everyone should get this because I don't know who's at risk for those diseases, but I do know this baby, if they were exposed, could be permanently blinded. On an individual basis, a lot of parents are like, well, I don't have that risk. I'm not worried about it. I think the other thing to think about are other bacteria. Where is the baby coming out and how close to a bacterial port is that? And so I think it makes a lot of sense. Another thing we often do is bathing babies. We don't like to do that right out of the gun. There's reasons why you don't want to bathe your baby in the first couple hours, but you also don't want to wait for that bacteria to grow up and build up in the eye. And so in general, we try to do the antibiotic ointment right away and then a bath later on.
Yeah. So Sarah and I, we both have 3 boys.
Mhm.
So let's jump into circumcision. What are the risks and benefits of
Yeah.
that? I feel like it's changed over time for sure.
It has. And I think every generation has these discussions. Do we do what the last generation did? Certainly, I think the number one reason people circumcise is probably still cultural. In certain cultures, it's the norm. And in others, they look at you cross-eyed like, wait, what are you doing? So if you look worldwide, it is not the norm. If you look at the U.S., it's much more common. And certainly in Utah here, it's very common. Medically speaking, risk-benefit, the medical reason to do it probably is most supported by the risk of a urinary tract infection. So boys in general don't have a high risk of urinary tract infections, but if you look at babies who are not circumcised, your risk is about 1 in 100 of having a urinary tract infection. Now, some urinary tract infections are pretty mild. You worry at a newborn, that gets into the kidney. You get scarring in the kidney, causes hypertension. So UTIs in newborns, fevers in newborns in general are big deals. If you are circumcised, that risk is still there, but it drops from about 1 to 1 in 1,000 versus 1 in 100. So that's the medical reasoning for it. However, I have a lot of patients who are circumcised, and it's not like I'm seeing infections in all of them. And I think it really does come down to parent preference.
Good to know.
Which paralyzes a lot of parents, right? It's one of the first decisions. Do I actually do this thing? And I should mention the timing of it as well. Studies would say circumcising a baby boy in the first month of life is tolerated pretty well. I don't remember if your kids were in the hospital or at the 2-week visit. Usually it's one of those two. So if everything's going well, we're feeding well, or bilirubin is not high, it probably makes sense to just get it done in the hospital. Then it kind of depends on timing. Are you ready when the pediatrician's ready for that? Sometimes that doesn't line up. We have all babies come back to repeat their newborn metabolic screening. He will poke at the 2-week visit. So that's another common time. Usually by then feeding's well, bilirubin, jaundice, things are fine, and it's a comfortable time to just have your circumcision as well.
Yeah. So what about lactation support, and how does a pediatrician fall into that category?
We have lactation in our office. Not every pediatric office has that luxury, and they're not there every day. Most nurseries have access to lactation specialists as well, and most insurance plans have somebody on their panel that's available. So I think it is a good thing, especially with your first baby or two. It can be a whole new world. And usually the problem lies somewhere between mom and baby, not one or the other's fault. I will point out, I think there's a big difference. This is from someone who's never breastfed, but I do think there is a big difference between what's going on those first day or two in the hospital and then once your milk comes in. So a lot of moms I'll see will get a lot of support in the hospital, and then they'll show up on day 3 to 4 really struggling. And when I bring up the idea of, well, maybe we should see lactation. Oh, I did that. It probably makes sense to look again if you're really struggling, because it's just a different game once your milk comes in. I'm told.
Well, I think we have to consider lactation support as always a benefit, never as someone who's coming in to, tell you you're not doing it good enough. Are you the one who first looks for like tongue ties, lip ties?
Yes.
Or is there a different provider who is evaluating if there is like a medical?
Yeah. It would be us, and it's a very controversial theme in general. There's not really good data one way or the other. You look at breastfeeding outcomes, that's a very individual thing. It's hard to stratify based on that. And so it's kind of a softer outcome. So most of the information or experience comes anecdotally, right? My last kid had a terrible tongue tie, waited too long, and it changed their life. I hear that all the time. Great. Maybe I'm going to be a little more aggressive and saying maybe we should do a tongue tie or clip that. There's also different ways to do it. If the way I do it in the hospital or in the clinic is just to clip it with some scissors quickly. There are laser procedures that can do that as well. Again, there's not a lot of great data saying one or the other. It's mostly anecdotal. I personally have not seen a lip tie make a huge difference. I haven't talked to a lot of dentists or specialists that feel like there's a lot of data to say that that's a big thing that's going to change your life. On the tongue, I should say, there's a lot of feelings one way or the other. A lot of that comes from our lactation nurse. I have a lactation nurse all the time where parents will come say, lactation, we really got to get this done. medically, I like to look at it and see, well, what does the tongue do? When you play with the tongue and lift the tongue, does it come out past the gum? Or is it bend over and can't get past there? You're trying to bring milk out. And so if you're just clamping down, that can be very painful. So the most common scenario here would be a nurse or the mom would tell me, they're really struggling and it's very painful. There's other reasons it's painful, but sometimes that can be the ongoing issue. And then I'll look and see, is this a nice clear little membrane there that's really tying the tongue down? Or does it look like there's pretty good movement? It comes out, and maybe this is just a time and teaching thing that will improve with time. That can be done over time as well. I had parents all the time were like, I'm really worried about this, family history of tongue ties, but it seems to be going well. It's not a kid I'm anxious to clip.
And can you massage or like do anything to stretch it while
You
you're
can.
working on that latch?
You can. It depends on the severity of it, but a lot of these mild ones, it's just getting some motion in that tongue. And so you can work with them. And, often that worry fades over the first week and you realize it's going really well. What's the point?
Right. And I think the concern for most parents when they're, interacting with their pediatrician about feeding their baby is that their baby starts to either lose weight rapidly or they feel the pressure that their pediatrician feels like their baby's not gaining enough weight. Can you tell us more about like how we can just ease our minds with breastfeeding or with formula feeding? Is it based upon like their stool? Is it based upon, like measuring how many ounces they're getting?
Yeah.
Like what's the big concern if a smaller baby isn't getting like big fast enough?
There's really two. One is nutrition. This is the fastest growth period of your entire life. You can't get behind. You want to be up there. But you're balancing that with normal physiology as you lose weight. You're supposed to lose weight. And so, and then all that has to be put in the context of what's your bilirubin. We talked about if your bilirubin's dropping or not dropping like we want, then you really worry that feeding could be part of the problem. So often the pediatrician is pushing the weight knowing that we don't want to have to worry about secondary things like bilirubin. So those are in conflict sometimes, right? We want you to just breastfeed and let physiology and natural learning happen, but don't lose too much. For a long time, we've used this idea that if you're 10% below your birth weight, you're probably in that threshold where we worry. So if you lose 8% the first day, you may not be at 10%, but your pediatrician starts worrying, where is this going? We're going quickly. There are some new tools that have been made available that a lot of us are using that help put it, kind of like bilirubin has a graph. We can see how it's charting out. Weight has the same thing. So more than just a percentage of your weight loss, looking at a percentage of babies. So looking at that percentage, and are you in the 90th percentile of losing weight? That would make me more worried than a kid who's lost a lot of weight, but you're still in that 50th, 60th percentile, meaning kind of the average. Then I can take some reassurance in giving it time. I think the other thing and this has to do with your relationship with your pediatrician sometimes, is how do I know you're going to go home and feed this baby to the point that we gain the weight we need to? And so there's a lot of variability. If this is just some random doctor in the hospital you never met, sometimes you feel a little more pressure and they feel put on more pressure because I don't know you. I just know I don't want the baby to lose weight. And so that's, certainly having those follow-up visits with somebody that has some continuity can be really helpful to see where we're at.
And what about a little bit later in life? So all of a sudden you've got, like this 8-month-old baby, or maybe your baby's 1-year-old, and they are not eating very well. And all of a sudden you're getting nervous because here they are, they've gone for 3 meals and they haven't really touched the food you put out in front of them. Okay, maybe they're a little bit older than 12 months if you're putting a plate of food in front of them. But
Start some food then.
what can you recommend?
Yeah. Well, picky toddlers.
Picky toddler. It's very different than the newborn, right? The intervention, because the toddler has a different problem, and that is this behavior around food. That it's hard. In America, we've learned and been taught to eat when we're hungry. If there's a donut there, it's like, there's a donut, looks good. And now we're dealing with the effects of that. Whereas what we really want adults and kids to do is learn to eat when you're hungry. And if that's a smaller dinner, then it's a smaller dinner because you're not hungry. And we don't always do that starting at a young age. There's a fear that if we don't eat, if we miss a meal, it's bad. So we'll You won't eat this, we'll eat that. And you start offering more and more things that the kid's learning. I just wait till it looks good now. And it may be ignoring those hunger cues. And then there's I'm just tired, or there's I'm mad at my sister. I mean, there's lots of reasons that behaviorally make it really hard to know how to intervene there. So the most helpful thing we have is the growth curve. Again, a percentile. Here's a cohort of a large sample size of normal kids. And you're going to have big normal and you're going to have small normal. So you're looking at where you're at percentage-wise. Are you at the 50th percentile, right in the middle, or are you high or low on that? But you're also looking at your growth velocity. Where's your kid visit to visit? And that is where these visits come in. We're seeing it pretty frequently in that first year. And sometimes the birth weight and the balance is confusing, but after a while, we want to see a pattern here. Is this a kid who's catching up? Is this a kid who's planing out? Or are they dropping each visit? So, 30 percentile sounds great to a kid who's been at the 15th percentile or always been at the 30 percentile. But if you've been at the 70th and you come in at the 30th, I'm asking questions. What changed here? So I think that well child visit, those 2, 4, 6, 9, 12 month visits can be really helpful to see where am I at, and does it fit the narrative of what's going on at home? If you feel like I'm doing really well, it seems like he eats when he's hungry. There's just some days he doesn't eat and he's tracking along really well. I'm not worried, but there can be a lot of variabilities in there. And I would say most of those are behavioral, but not always, which is why you want to touch base and talk about it when you see it.
Yeah.
And before we depart the topic of feeding, how can we help our children when they are experiencing reflux?
Yes.
So here they are, they're a small baby, or maybe they're even a little bit of a bigger baby, and they are uncomfortable and spitting up or, showing other signs of reflux.
So reflux is a normal thing. That little muscle that's holding your food in at the top of the stomach is not very well formed. And so having spit up is a normal process. So then the job is trying to quantify that. How do you quantify how much is too much? Which is very subjective. You spill a cup of milk on the floor, it can really spread out. A small amount of spit up can soak you. So you come in and say, this kid is spitting up crazy. Again, you look at the growth chart and go, they're growing really well. So clearly we haven't crossed that line of I'm spitting everything up, but it can feel that way.
Oh, yes, it definitely can.
Yeah. So that makes it hard to know, well, when is it a problem? There's certainly conditions, there's diseases that I really worry about that we don't want to miss. I think the term projectile vomiting probably gets overused. Historically, that's been used for a kid. The muscle at the top that's letting the reflux come up. But there's a muscle at the bottom too that slows it down so we don't go too quickly through the gut. We can absorb it. If that muscle gets overgrown, then projectile vomiting is because that balloon above it fills up to the point where it comes out, hit the wall. And that's more of an emergency. You've got there's procedures where they'll cut that muscle to open it up, because those kids will lose a lot of electrolytes and get a lot of problems with sodiums and potassiums quickly if they can't pass things through and absorb it and they're throwing it all up. So that's when you don't want to miss. But most kids don't have pyloric stenosis. Most kids have some normal physiologic reflux. I would say that peaks around 2 months usually. So you're a couple weeks into it going, well, this is annoying. And then you come to your 2-week visit and I'm like, you're fine. That's just normal. So there's a couple interventions, reflux versus colic sometimes is hard to figure out. So there's a lot of over-the-counter things like probiotic drops, add some helpful bacteria to help digestion. There's simethicone, which helps with gas bubbles, gripe water. So there's a lot of over-the-counter things that may or may not change your child's life, but probably don't hurt. The question is always when to start an acid blocker. That's a medicine that lowers the amount of acid. Usually I'm looking for a kid who's arching and a lot of pain. Pretty consistent. It's not just those bewitching hours in the evening, but it's most feeds are causing that. And a pattern of this is worsening with time. And so at some point we make that decision, and hopefully it's a joint decision of we should probably try some acid blockers. And there are kids that makes a big difference for. The risk for it, and the reason it's not the first line we should just put every spit up kid on, is if you look at large populations of babies on acid blockers, there's a higher risk of infection. which kind of makes sense. Acid kills infection. You lower the acid, you make it more infection.
Hmm.
I wouldn't say I see that with every baby that I put these on an individual basis, but it's something to consider before you just knee-jerk, let's do that acid blocker. But the kids that are on it, it can help. And usually if I'm going to put a kid on an acid blocker, we'll do it for a month and go off and see. Because at some point, almost all these kids grow out of this. Whether that's 2, 4, 6 months or 8 or 12 months, kind of depends on the kid. But I don't want to just do this acid blocker, even if it's a low risk, for longer than we have to. And so once a month, you take them off and nothing changes, you probably grew out of it. If you're right back where you were last month, then probably need to get a refill and keep going.
And if the baby is breastfed, how can altering the mom's diet affect it? Like if she goes off dairy, does that often make a big difference, or is it like too subtle to really make a difference?
Most moms jump to that very quickly. I don't know if it always makes a huge difference. I think it feels like an appropriate sacrifice to a mother. No one asks the dads to stop drinking dairy because mom's doing it, but
or having their ice cream.
Yeah. So it's sometimes it can feel pressure to do it, and I don't know if that always makes a difference. I don't think it's a bad thing to try, but if you're someone who feels like that's asking a lot and you're doing your best, I don't know that you need to start there.
In my own experience, it felt like there was a couple of weeks and months that it actually made a difference, but it was really mainly for cow's milk. And so if I drank some almond milk or some oat milk, it seemed to have a better effect on my baby. But then there's other foods as well, if you're breastfeeding, that can cause reactions, right? Like if you're eating a lot of broccoli or cabbage, like your baby might not be as happy with you.
And you're the expert because you see the immediate effects. You don't need my permission to say, let's try this for a little bit. The other thing you got to think about is the maturity of the gut. That's a moving target. It's changing significantly, which is why we do cow's milk at a year. By that point, it's matured to the point to break that protein down. So anything you do, give it a few weeks and maybe try it again. If your baby's having blood in the stool, that's a different scenario. And there are some diets we'll do to try to remove certain things and see if that helps. But in general, I would say, if you've been off dairy for 2 or 3 weeks and it really helped and it's a sacrifice, try it again, because we may be to a point where it's working again.
Yeah. Well, we've asked a lot of our commonly asked questions. Are there ones you get asked often by parents?
Yeah, I think a lot of those depend on the developmental age. Every age has this question. Right? It's things that no matter what your parents told you or how much you studied, you didn't see that coming. And so those very often developmentally will pass. I think one we jumped over was the newborn. What are you going to do to my baby at birth? And we touched on the vitamin K. We touched on the erythromycin ointment or the antibiotic ointment for the eyes. And the third one's the vitamin B shot, which is another one I get a lot of questions about. And I usually come at it from a standpoint of public health again. I don't know your risk factors. But hepatitis B is a vaccine or is a disease that causes really bad liver damage and often leads to liver transplant. So even a low risk, if you were that person, that low statistical risk, it can have bad outcomes. So if you look at populations of people that have hepatitis B, about 20% have it and don't know they have it. So if you walk in the hospital, my recommendation is get the vitamin B vaccine, because it's not only a preventative thing, it's the treatment. If you treat a baby at birth with the vitamin B vaccine, you're treating in a way, you're helping treat the disease. There's other treatments we would do if you were positive, but it's a really helpful preventative thing. Now, if you don't have any risk or you don't feel like you have any risk and you choose not to do that, it is bundled in with the vaccines at 2, 4, and 6 months. And so there's other ways to get it. It's just, it only helps treat it if it's in that first window, birth. And so it's pushed at that one. The rest of them, between antibodies and breast milk and things like that, the vaccines usually start at 2 months.
And when we're looking at the vaccine schedule, is there a benefit in delaying some of those vaccines or doing them one at a time, or should we follow the recommended schedule?
Yeah, I get that question all the time. And my take on that is I'm here to help educate on what I've seen, what I've read, my experience. You're the parent. You've got to make these hard decisions. What I worry about is the parent frozen somewhere in between, right? I've got family or neighbors telling me this, my doctor's telling me this. I don't know. I guess I'll do nothing. Um, it's probably not a great way to raise kids, but I think a lot of parents feel this pressure and it's easier to do nothing. Um, there certainly are benefits to vaccines, and the vaccine schedule, 2, 4, 6, 12, 15, 18-month vaccines. So the bulk of the vaccines are done in the first 2 years, has not been changed in a very long time. These are very well-studied old vaccines that have been shown over time to be safe and effective. I think it's important to understand that when a vaccine comes out, there's studies that are done. And those studies have anywhere from maybe 40, 50,000 kids in those studies to decide if it's effective and if it's safe. And if that's done, then we typically get some kind of approval to start using that vaccine. To me, the most valuable information are the studies done afterwards, the surveillance that's done after. And so, after a couple million vaccines, you've really got some data. And that's where the vaccines we do in the first 2 years all have lots of surveillance data. And we review those every year. We make little tweaks to the timing or the combinations based on surveillance data, what works well. As a pediatrician, I'd like to combine as many as possible. My experience is getting vaccines is a bad day. Whether you get one or multiple, it's a bad day. So for my own kids, I felt like I'd rather put them together as the schedule outlines so that I have less bad days, less pokes. I'm bringing them in less. A lot of parents feel like spreading them out. I think intuitively that does make sense. Feels like you're overloading the system. That's not what the studies played out. It showed it's that amount of antigen seems to be well receptive at that age in those doses in that frequency. One of the downsides of delaying vaccines is we don't have a lot of good data. There's books out there talking about this alternative schedule, that alternative schedule. Those are very much based on intuition and less on what is the actual data with these vaccines that we have. So as a medical doctor, I'm recommending what I'm seeing in these big studies. And when we start varying from that, I make some assumptions too. I think it's as effective. I think it's as safe. But I can't say that I have big data to show that. Your risk for individual disease is hard to predict. So those vaccines, for example, the 2-month vaccines, the first one, the tetanus, diphtheria, pertussis, hepatitis B, and polio are combined into one. And then the Haemophilus and the pneumococcus are the other pokes. And then you have the rotavirus, which is oral. And those all have different risk factors, different reasons why they're given at certain times. And then there's a difference in how many you need, again, in these studies to show, are they effective? And trying to predict your risk, I think, is a really hard thing to do. Oh, I keep my baby at home. Yeah, we all try to keep our baby away from sick people. And that's hard. And that's where you see these outbreaks. This year there's been a lot of measles outbreaks. And so knowing who's the person that's going to walk by you with measles is hard to know. We learned in COVID that staying home and sheltering in place probably isn't the most effective long-term strategy for staying healthy. There's some payback and immune debt the next year. So in a way, we all have to take risks of being exposed. And I think vaccines are a really good way to balance that risk.
Well, each episode we share a Mom Squad secret for that week. And we wanted to share from Chris. Says, when you're feeding a baby from an empty tank, it will add up and take a toll mentally and emotionally. Keep drinking and eating, especially when you're sleep deprived and don't feel hungry. Just as we've been talking a lot about food today, we cannot pour unless we drink as we pour. So we need to be nutritious as well as we're giving that nutrition to our baby.
I would dovetail on that comment. I think there's a lot of pressure to breastfeed, and there's a lot of reasons to breastfeed. I mean, certainly with all the advances in formula, antibodies are not one we're able to duplicate well, especially when you think about local antibodies and risk in your area. So I think there's a lot of reasons to breastfeed, but if it's putting you over the edge, there's really good formulas out there as well. And there's plenty of smart people in this world who were bottle fed by formula and still graduated. So balance that pressure to breastfeed with taking care of yourself.
Yes, agreed fully.
We love to ask about resources.
Yeah.
Any books that you recommend for us new parents?
There are a lot of good books. There's a lot of good apps too. One's called Milestones. It's an app that's done by the CDC, and it becomes your own little developmental milestone tracker. And so you can kind of follow along. Certainly at every well child visit, we're going to talk about developmental milestones. We like to screen kids. There'll be questionnaires for parents to really kind of dial in where are we at. It's not always about one milestone versus the trend of where we're going. And certainly any regression would be concerning. But yeah, the Milestones app is fun. You put your baby's name and birth date in there, and it kind of tracks along with you. And you can put in what they're doing, and it can give you more immediate feedback about how that's going.
And when there are missed milestones, are there any we need to pay particular attention to? Something that would be a concern, like, hey, call your doctor if your
Yeah.
baby is really missing or like digressing, like you mentioned.
There's very few that I'm like, today you need to get in. Usually that would be more infectious stuff. But I think more of the kid who is stalled out in one specific area, some kids will go from rolling to sitting to crawling to walking. But some kids don't do a lot of rolling. They just start crawling. Or they'll go from crawling very shortly or just pulling up on furniture to walking. So it's not about checking off every milestone as much as it is getting new skills, new things that you can do over time. And so if you're looking back and saying, my kid's been stuck here for a while, if I'm seeing it at the 2, 4, and 6 months, and at the 6 month, you're going, we're still talking about the 4-month thing, we should talk about it. If there's been if your baby fell or had some trauma and we've lost them for a while, those are always hard to know. Is that related? Have it been delayed? And time usually tells. I like to kind of track these developmental screeners. There's certainly developmental tests, but they're harder to quantify always. So having a couple questions can help the pediatrician really decide, this kid needs to be on my radar or not. There's 3 areas of development you're watching too. There's speech, which I would include feeding as speech early on, but then it's certainly into words. There's gross motor, the grabbing, walking, trunk control. And there's fine motor. Are you starting to grab things, eye-hand coordination, stuff like that? So all of those realms may develop differently. Your friend may have a baby who's walking really early, and you may have one that's talking really early, but vice versa may not be true. They're both developing and probably developing normally. So the things I want to hear about are stalling out in any one area, not learning any new tricks for weeks and weeks, and any regression. I was walking, now we won't walk. I was rolling over, now has no interest, and it's been weeks and weeks. So those kind of things would make me think more of something we need to dig into.
I know you're passionate about reading to children.
Yes.
Is there a scientific reason why we should start reading to our children right from the start?
There's a bunch. I think, the Reach Out and Read programs, a program throughout the country that most clinics participate in, and if they're not, they should, where we give books. And that is modeling to parents, this is something valuable. There's 100 things we could talk about at every visit. I want to make sure we're talking about that at that visit. It goes through all those developmental things. First, 6 months, I hand a baby a book, goes straight to the mouth. I want to see that, because if they don't, it makes me wonder, why aren't we putting everything in our mouth? That's a normal thing to do. But then it goes to turning pages, or you have that fine motor to turn a page. And then there's the, starting to use words. If you think about it, when your kid's learning the words, it's stuff they see. And they don't see everything. So books allow you to see other things and put labels on them for it.
Yeah.
And then I think the most important one is, what is the alternative to book? Screens. And we know that a lot of screen time under age 2 really stunt that brain development. And, you wonder, why are we having all these problems coping with stress? There's some stress in learning how to turn a page or navigating a book. And you learn those really young. There's creativity in that as well, that you can't make up for later in life. And so I think there is certainly a correlation between mental health as a teenager and creativity and exposure to those kind of things really early on. And so trying to avoid screen time, doing more creative play and being present with your kid in books is an easy way to do that. Plus, it's fun. Reading to kids is fun. And I think that bonding is a really important thing, which there's educational programming and other things that don't give you that. You can't make up for it in other ways.
Do you have a favorite age?
7 months.
7 months.
There's a sweet spot. It lasts about 2 weeks in my experience, where you're sleeping, you don't have colic, you're spit up, you're eating pretty well, but you don't crawl and run away from it yet. And it's beautiful. I would have froze all my kids there if I could have, but they've grown up and past that. But I love that age. Sometimes it's 6 months, so don't miss it. But that's my favorite.
Do you have anything else that you want to share to our listeners?
I would say when it comes to learning about your baby and what your baby needs, do your research. And I think it comes down to you've got to decide who you trust. I think that's hard. It's hard to know who to trust. There's some very confident people online, and it's hard to know if we should trust everything we hear online. I think it's very valid to ask questions about things you've seen. Most pediatricians have been asked all those questions, so there's not an offensive question out there. There's new things coming around all the time too, though. And I think if you can ask those questions to people you trust, you'll make good choices. And I wouldn't discount your gut. As a parent, you are given an instinct that your pediatrician doesn't have for your baby. I have experience. I have knowledge on diseases and studies, but I don't have that gut instinct. And so if you're worried, you should reach out and discuss that. And if it's not the answer you want and it persists, talk about it. And I think that's where just as valuable as showing up to your well child visits and having, checking the weight and developmental things is building a relationship. If you call me with a 2-year-old that I've seen 7 or 8 times, I have a lot more insight to help you than if I've never seen that kid. And that's a disadvantage ER and urgent care doctors have is I don't know. And sometimes you have to do more in those situations to cover your bases versus if there's a relationship there, some continuity, it's a lot easier to have some shared decision-making that we're both comfortable with because we've seen how this has played out before. There's a pattern of this or that.
Well, thank you so much. This has been so valuable. I can just imagine myself as a first-time mom having a resource like this where all those questions are answered. I learned them over time, but to have had one of them in one episode, I know is going to be very valuable. Well, thank
Fantastic. Glad to help.
I remember when I used to come to appointments, I had so many written down for my firstborn son, and I had a little note section on my phone. And my second son has a few questions, and I can't find any questions for my third. So you did a great job answering our questions, helping us feel confident in raising our children. So thank you so much, Dr. Schmidt.
It's a common pattern. It starts with a lot of questions. And there's a second curve, teenagers, the list gets long again. So we can circle back.
We'll be back at it. Thank you so much for being on the podcast today.
Thanks for joining us on today's episode. We hope you've been elevated and inspired by this week's expert.
Subscribe today so you never miss an episode. And please share our podcast or post on your social media so that other moms and dads-to-be can also have the best birth.
Please note that the information provided is based on the expert's insights and personal experience. It is not intended as medical guidance. Please seek the advice of your medical provider as it applies to your specific condition.